Yeah, sure.
Yeah. Good evening, everyone. So I'll be presenting a case of seronegative acute placoid chorioretinopathy. Basically, I'll discuss on the role of multimodal imaging in diagnosis and management of this case. Okay, so when we speak about acute placoid chorioretinopathy, the thing which comes to our mind is it is characterized by sudden onset, well-demarcated placoid lesions at the level of outer retina, RP, and choroid, and mostly affecting the posterior pole. So nowadays, in today's world, whenever we speak about acute placoid chorioretinopathy, the first infective cause which we need to rule out is syphilis. Besides, there are other causes like inflammatory, autoimmune, drug-induced, and paraneoplastic causes also described. So coming to our case, a 28-year-old male presented with sudden onset painless diminution of vision in right eye since 4 days. He was a shopkeeper by occupation. There wasn't any systemic history, and there wasn't even any history of high-risk sexual behavior. The best corrected visual acuity in the right eye was 2/60 with occasional AC cells and retrolental cells. Left eye was within normal limit. Coming to the right eye fundus photography, we could see RP mottling and dull foveal reflex, and one might say there was a yellowish hue also present here, which was a subtle yellowish hue present along the infratemporal arcade. The left eye was within normal limit with preserved foveal reflex. So we did a fundus autofluorescence. I'm sorry for the asymmetry in the pictures, but if we correlate the locations in both the eyes, we could see increased hyperautofluorescence along the infratemporal arcade in the right eye. And besides, there were also multiple discrete hypoautofluorescence dots at the posterior pole in the right eye. So coming to the OCT, we could see there was intact external limiting membrane. However, there was disruption of the ellipsoid zone, thickened and granular hyperreflective RP with nodular elevations, very characteristic of the rosary bead appearance which we talk about. The left eye was within normal limit, and the first thing which came to my mind was whether I was dealing with a patient with acute syphilitic posterior placoid chorioretinopathy. So I got the investigations done, but to my surprise, all came out to be negative. Also, we ordered for PCR, but unfortunately, it was not done. So I couldn't go with an invasive treatment because the results were negative. So I planned to treat the patient with doxycycline 100 mg BD for 28 days. And to my surprise, at 7 days follow-up, there were already a reduction in the thickening of the RP with less granularity, and visual acuity improved to 6/18 at 7-day follow-up. Even if we see the fundus photograph, there was reduction in the dullness of the foveal reflex and the yellowish hue along the infratemporal arcade. But I repeated the TPHA and VDRL under dilution at 3 weeks because I thought probably I'm dealing with an early case of syphilis, but it came out to be negative again. And at 7 days follow-up, even the hyperfluorescence was also reduced. So at 4 weeks follow-up, there was complete resolution with visual acuity of 6/6, and the hyperautofluorescence has completely resolved. Even we did an OCT angiography where we could see a reduction in the vessel density, and there was flow deficits in the right eye, and there was better vessel density in the left eye. So what is unique in my case was it was the ASPPC-like lesion with repeatedly negative TPH and VDRL, which challenged the classical association with syphilis, and rapid resolution with doxycycline therapy suggested a potential alternative infectious or inflammatory cause, and because of the reduced vessel density, probably there was also an microvascular involvement. Multimodal imaging was crucial because only looking at the fundus photography, it was inconclusive, and it also brought a differential diagnosis of placoid chorioretinitis. The clinical implication will be, even though serology was negative, repeated testing is crucial, and if required, a double serology test should be performed to avoid false negative results. And in cases where ASPPC-like lesions are present and you are thinking about infectious etiology, a trial of doxycycline may be justified. My take-home message will be not all ASPPC-like lesions are syphilitic. We need to repeat serology. We should rely on multimodal imaging and also consider alternative infections. Thank you so much.
Thank you.